எல்லாம் பிரிண்ட் எடுத்து ரெடியா வச்சு நாங்கள் பண்ணிட்டு கொடுத்துருக்கோம்.
Sir, shall we start, sir?
Fine.
Thank you, sir.
Just let the confirmation come from the IT team. Just the IT confirm.
Okay.
Actually, they take 1 minute after they show that it's live.
Okay.
Once they confirm, we start. It will take one more. Hardly one.
No issue. No issue.
¿No? Ni todos con la comida.
8:28. కాకపోతే తాళ్ళు మండలమా వాళ్ళు రెండు డిప్రెషన్ విధంగానే ఇస్తారు.
Dinesh, can we start?
Yes, sir. We are live.
Okay, Jyotiji, we can start. We are good to go. Thank you.
Yes, sir. Yes, sir. Very good evening to one and all. And on behalf of our Curious Mankind Specialities, I am Jyoti Kumar, Regional Manager, based at Chennai. And I am welcoming you everyone for our meeting today on topic regarding dapagliflozin, current perspectives and future outlook by our beloved speaker, Dr. Shreedhar sir. He is the head of the Department of Technology and Diabetes, MIOT International, Chennai. And I am very happy to introduce our speaker today, Dr. Shreedhar sir. He finished his education majorly in MBBS and MD both in MMC Chennai and DM Endo from AIMS Delhi, and also he has done FRCP from Glasgow. And he is having almost more than 30 years of experience in endocrinology and has presented almost 26 papers in index journals. And he is also having the pride in serving as past president of Endocrine Society of India, the Tamil Nadu chapter. And also we'll be very proud in saying that he is a doctor, is winning a Best Doctor Award from Tamil Nadu MGM Medical University 2012. And also he is the professional membership is having in API, Endocrine Society of India, RSDA, and even ADA. And today definitely sir's experience will give a lot of insights in dapagliflozin as a molecule. Today also I just received from the renowned Dr. Braunwald about dapagliflozin as a molecule is the statin of 21st century in all cardio, renal as well as metabolic complications, the drug of choice. Definitely, doctor will give a lot of insights today for us to have a better better molecule to be used in future. Over to you, sir.
Please, can I share the screen?
Yes, sir. Visible, sir.
Is visible?
Yes, sir. Visible, sir.
Okay.
Loud and clear, sir.
Okay. Good evening to everybody. It's a stormy evening in Chennai, and I request all of you to keep safe, and I thank Curious Mankind for this splendid opportunity to talk about, as what told earlier, the statin of the 21st century, dapagliflozin, current perspectives and future outlook. The Western countries, at least, have achieved substantial reduction in death and hospitalization from cardiac failure, as you can see, over the last 2 decades. Death from cardiac failure, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease has come down considerably, as this data from the Swedish National Diabetes Register on a whopping 457,473 patients with type 2 diabetes and followed up for 6.5 years. But even though we are happy with this news, you can see the blue chart where always the diabetics are still doing badly when compared to the controls, be it death from CVD, be it death from coronary artery disease, or the hospitalization for CVD. There is a substantial burden which still remains in diabetics, the type 2 diabetics. So why does this cardiovascular disease occur? In type 2 diabetes, there are already risk factors. Basically, the person is obese, he is physically inactive, hypertension is a common associate, lifestyle problems like smoking, a very poor diet, etc. The common complication of diabetic dyslipidemia, and already the metabolic syndrome, which is insulin resistance syndrome, which is already the precursor for type 2 diabetes and cardiovascular disease. These are the risk factors. But once the diabetes sets in, the hyperglycemia itself causes a lot of problems. It causes arterial stiffness and also endothelial dysfunction, causes excess platelet activation. We all know that diabetes indeed is an inflammatory state characterized already by metabolic syndrome and metabolic dysfunction. And together, the risk factors and the direct effects conspire jointly to cause cardiovascular disease in type 2 diabetes. In a comorbidity-free population from all countries, 18% of the patients had a first event during a mean follow-up of 4.5 years. This was according to a study by Berkland et al., which was published last year. And they found the first comorbidity, 24% was heart failure and 36% CKD. Altogether, 60% was constituted by cardiorenal diseases. A further 40% was contributed, 10% by peripheral artery disease, 16% by stroke, and another 14% by myocardial infarction. And if you, with the advent of the echo, we see so many times that undiagnosed heart failure is a common phenomenon. When we do an echo as a part of a routine examination in a diabetic, many a time we'll see type 1 diastolic dysfunction. Now, earlier we used to think it's a benign condition. No, it's not benign. It is a type of early diastolic cardiac failure. And 16% of the patients present with this, 27% have actual systolic LV dysfunction with a reduced ejection fraction, and 25% have both. Only 32% have a normal LV function, even though they are asymptomatic 5 years after type 2 diabetes. And undiagnosed in another study in 581 patients, which was published about 8 years ago, 72% had no heart failure, but 28% had heart failure, predominantly with the preserved ejection fraction, 23%, and 5% with the reduced ejection fraction. So the moral of the story, type 1 diastolic dysfunction is not benign. It is an indicator of subtle diastolic heart function dysfunction. So what are the interrelationships between heart failure, type 2 diabetes, and other CVDs? 35 to 45% of patients with heart failure have CKD. 20 to 44% of patients with type 2 diabetes already have CKD 2 and 3. And 60% may go up to 4. And 12 to 45% of patients with type 2 diabetes have heart failure, and 32% of type 2 diabetics have CAD. While in the Western countries, the cardiovascular disease like coronary artery disease is going up, such success, similar success is not seen as regards of heart failure. Why? Because there are many factors. First, there is an oxidative stress. The dyslipidemia which occurs in diabetes causes lipotoxicity. High blood sugars causes glucotoxicity. And the perpetual insulin resistance is especially present, even preceding the diabetes is a risk factor. And the formation of the advanced glycation end products and the reactive advanced glycation end products are another risk factor. All of us know diabetes is an inflammatory state, and there is sodium and hydrogen exchanger activation. Together, all these factors create a vicious cycle leading to endothelial dysfunction, micro and macro angiopathy, cardiomyocytes hypertrophy, fibrosis, mitochondrial remodeling, apoptosis, autophagy, and cell death. Together, they lead to this unique and sort of malignant condition, diabetic cardiomyopathy. Besides this, other conditions like CAD, hypertension, CKD, all contribute, and together they lead to heart failure in diabetes. Now, the Asian diabetic is unique. Why? Why are they unique? Especially the South Asian. They usually have almost a decade younger onset of type 2 diabetes. So with the advancing lifespan, these people live with diabetes for a longer time. The Indian is known as the thin, fat Indian. Why is he called thin, fat Indian? Because his BMI may be normal, but is abounding in visceral adiposity, which is metabolically much more dangerous. And generally, when compared to the Westerners, we have poorer beta cell function and much higher rate of cardiovascular complications. So we actually need a drug, not only which is glucocentric and causes just blood sugar reduction, but we need a drug which sort of covers all these problems. So in this context, the so-called new statin of 21st century, the SGLT2 inhibitor, offers potential benefits. Sustained long-term data is available that it causes less hypoglycemia and can be more advantageous in a working population. And since it causes weight reduction, it's not only the subcutaneous fat, but visceral fat is reduced with, very importantly, a reduction in abdominal circumference. Now, for the metabolic syndrome, the waist circumference is very important. You take an inch tape and keep it around your umbilicus. Then if it is more than 90 centimeters in a male and 85 centimeters in a female, then it is considered obese. And this drug is especially important because it causes reduction in abdominal circumference. This drug doesn't depend on the pancreas. It's got an insulin-independent action. And it reduces glucose, it reduces weight, it reduces the blood pressure, and has possible neutral effects on lipids. And hence, it modifies 3 cardiovascular risk factors. As all of you know by now, the SGLT2 inhibitors like dapagliflozin predominantly act and selectively act on the proximal convoluted tubule and inhibit the SGLT2. And roughly about 70 grams of glucose is excreted. So because of this, as all of you know, 1 gram of glucose has 4 calories. So 280 calories are roughly lost in the urine every day. And this is the mechanism by which weight loss occurs. And while causing osmotic diuresis, the SGLT2 inhibitors have a good, reasonable effect, especially on the systolic blood pressure. And as told earlier, it acts independently of insulin mechanisms and works regardless of beta cell function. There is low propensity for hypoglycemia, and it complements rather than antagonizes the insulin-dependent mechanisms. The SGLT2 inhibitors like dapagliflozin, they have a rough 0.8 to 0.9% reduction in HbA1c. And it is consistent, unlike an SU, which shows dramatic reduction initially, but it sort of wears off because the beta cells tends to escape from its action. Here, in this study showing 6 months, 24 weeks, the reduction is consistent. So in monotherapy, it causes about 0.89% reduction as compared to placebo, 0.23%. In comparison, in addition to metformin, it causes an additional 0.5% reduction. When added to SUs, an additional 0.7% reduction. And even when added to insulin, it's a good combination to add with insulin, and it causes additional 0.6% reduction. When an SU is compared with with the dapagliflozin. Dapagliflozin plus metformin will cause not only weight loss, but a much lower incidence of hypoglycemia. So almost 50 times less hypoglycemia when compared to even a short-acting SU like glipizide. So you can imagine how much different it will be with a long-acting drug like glibenclamide. And when compared with a combination of glipizide plus metformin versus dapagliflozin for metformin over 2 years, that is 104 weeks, it's well known that metformin is weight neutral and glipizide will cause weight gain. So there was a slight weight gain with glipizide plus metformin at the end of 2 years, whereas because of the dapagliflozin, there is a net reduction of nearly 4 kilos of weight. So all in all, it's a difference of 5 kilos between DAPA plus metformin vis-a-vis glipizide plus metformin. Now, SGLT2 inhibitors on top of metformin, the SGLT2 reduction in EMPA is 0.7. In CANA, 100 mg is 0.73 and DAPA 10 mg is 0.84. Weight loss is roughly similar with dapagliflozin minus 2.9 kilos. Blood pressure reduction is marginally better in systolic with the dapagliflozin compared to CANA or EMPA, and even the diastolic blood pressure reduction is somewhat similar. So how does dapagliflozin influence CV outcomes? Now, the DECLARE-TIMI trial was one of the landmark trials, and it is for a cardiovascular outcome study in SGLT2 inhibitors. And it is definitely the largest trial among type 2 diabetics patients. Now, the choice of patients differ in DECLARE-TIMI on dapagliflozin, CANVAS on canagliflozin, EMPA-REG on empagliflozin, and VERTIS-CV on ertugliflozin. Both EMPA-REG and VERTIS-CV both were secondary outcome trials. In other words, almost 99% of the patients in both the groups had already had a cardiovascular event, and prevention of another event, or otherwise secondary prevention, was the aim. In CANVAS, 2/3 had an event and 1/3 were at risk for event. That is, 2/3 were secondary prevention, 1/3 was primary prevention. Whereas DECLARE-TIMI, 60% was primary prevention and 40% was secondary prevention. So the largest trial on primary prevention was with DECLARE-TIMI. And here, the 17,160 patients with type 2 diabetes with the HbA1c between 6.5 and 12, greater than 55 years for men and 60 years for women, with one CV risk factor, were chosen 1:1, a double-blind trial, and compared with placebo. The primary safety endpoint was composite of cardiovascular death, non-fatal MI, or non-fatal ischemic stroke. And the primary efficacy endpoints was the MACE, that is maximum adjudged cardiovascular events, and composite of hospitalization for heart failure or CV death. Renal events were the secondary endpoints, along with all-cause mortality. And if you see the DECLARE-TIMI, the age group chosen was the highest, whereas The HbA1c also was the highest when compared to the other two. As I told you, established cardiovascular disease was only 40%. And as I told you, the primary and secondary endpoints were adjudged. And the baseline characteristics were roughly similar in all three, except when you see there were more number of patients in the normal GFR group, and also significant number of patients in the 60 to 90 ml group, and also in the less than 60 ml group. Whereas also patients with normoalbuminuria, microalbuminuria, and macroalbuminuria were there. But overall, the patient population with EMPA-REG outcome study on empagliflozin had much more advanced CKD when compared to the DECLARE-TIMI trial. And the multiple risk factors include LDL greater than 130 or a patient on lipid-lowering therapy, hypertension, or patients on antihypertensive therapy or BP greater than 140/90, and current cigarette smoking more than 5 cigarettes per day for 1 year. And established cardiovascular disease, age was 40 years, either having IHD, CVD, or PAD. So what was exactly seen regarding hospitalization for heart failure and cardiovascular disease? The DAPA group had 17% lower events. And as far as the MACE, there was 7% lower on DAPA group when compared to placebo. And if you see the meta-analysis of the hazards ratio, then the DAPA group had 10% less when compared to others as regards atherosclerotic cardiovascular disease. And for maximum risk factors, it was unity. The primary efficacy endpoints was roughly 21% less with persons with history of heart failure, and if there is no history of heart failure, 16% less. And another thing, dapagliflozin showed cardiovascular death benefits or hospitalization of heart failure benefits, even when patients with low ejection fraction. In fact, less than 30% also, there was 59% improvement in hospitalization for heart failure and 61% reduction in cardiovascular death. As far as the secondary endpoint was concerned, the renal composite endpoint, in DECLARE, there was 24% reduction of the renal endpoints. And when compared to EMPA-REG, the patients in the DECLARE trial, as told earlier, had better baseline renal function when reduced microalbuminuria when compared to the EMPA-REG. Adverse events were as on expected lines. A very small incidence of hypoglycemia. The fear of ketoacidosis was hardly there, and there were no evidences of any amputations, which was a fear, especially among canagliflozin patients. And so also fractures, there was no extra incidence, and also fractures are more known in canagliflozin patients. Malignancies were negligible. There was no chance of any acute kidney injury. As expected, the urinary tract infection and genital infections were the significant only. Now, another landmark trial on dapagliflozin, which elevated its status from a diabetologist's darling drug to a cardiologist's pet drug. This was the landmark DAPA heart failure study, where the primary outcome was cardiovascular death, hospitalization of heart failure, and urgent heart failure visit by diabetic status. And it was found there was 25% reduction in type 2 diabetics when compared to placebo. What was remarkable was patients with non-diabetics were also included in this category, in this study. And they found the results slightly better in non-diabetics. There was a 27% compared to 25% in diabetics reduction in heart failure. And last year, the DAPA CKD trial was published. And this also, the composite outcome was more than 50% eGFR decline, ESKD, renal or cardiovascular death, whopping 39% risk reduction in all these events. Now, this drug, dapagliflozin, and there is a future drug which is coming with mineralocorticoid receptor antagonist, finerenone. These two are the drugs for tomorrow for diabetic CKD. And dapagliflozin is useful. You don't have to be a diabetic. Just like you don't have to have diabetes and have heart failure, you can use this. Similarly, up to GFR 25 was studied in dapagliflozin, and now the nephrologists are also using it in greater number. So in October 2020, a statement was made that among patients with CKD, regardless of the presence or absence of diabetes, the risk of composite of a sustained decline in the estimated GFR of at least 50%, ESRD reduction, or death from renal or cardiovascular causes was significantly lower in dapagliflozin than with placebo. So what are the current recommendations? This is the 2021 latest this year current standards in treatment of diabetes according to the ADA, where the first line therapy is, of course, metformin and comprehensive lifestyle changes. And thereafter, in addition to the HbA1c, the risk factors should be considered. And if the person is having atherosclerotic cardiovascular disease, then the choice is either a GLP-1 analog like liraglutide based on the LEADER trial, or the SGLT2 inhibitor like dapagliflozin, which is already proved. If there is heart failure, it is the other thing. SGLT2 inhibitors along with metformin are drugs of choice. Here, there is the proof has come that SGLT2 is extremely useful in reduced ejection fraction heart failure for less than 45% EF. But the latest data on the Emperor Preserved trial on empagliflozin has shown that even preserved ejection fraction patients benefit equally. So naturally, all forms of heart failure seem to be benefiting from this. Then if a person is having DKD or diabetic kidney disease and albuminuria, without doubt, the choice would be an SGLT2 inhibitor with the evidence of reducing CKD progression, as in dapagliflozin, or GLP-1 analog are choice of drugs. And according to the recent data, up to 25 ml they are using, but nowadays even lower ones they are using, but up to now it's licensed for 25 ml GFR. If there is compelling need to minimize hypoglycemia, along with DPP-4 inhibitors, GLP-1 analogs, SGLT2 inhibitors, TZDs are drugs of choice. For minimizing weight loss, minimizing weight gain, or causing weight loss, again, GLP-1 analogs will be the drugs of choice. And the second is SGLT2 inhibitors. It will be a dream combination if you use metformin SGLT2 inhibitor and a GLP-1 analog, patient will achieve great weight loss. Only when cost is a major issue, drugs like SU and TZDs are used. But now with dapagliflozin going off patent and a drug like Justosa available at a very competitive price, now this also doesn't, the SGLT2 inhibitor can be used here also. In ADA, in patient guideline, if the patient is having ASCVD, heart failure, and CKD, this is the therapy which is already told. So, according to the European Society of Cardiology, in a person with heart failure with reduced ejection fraction, they recommend an ACE inhibitor, they recommend a beta blocker, a mineralocorticoid receptor antagonist like spironolactone or eplenolone, and dapagliflozin or empagliflozin, or an RNA like sacubitril with valsartan. So these are the 5 pillars of therapy indicated in treatment of NYHA classification class 2 to 4 heart failure with LVF, EF less than 40%. So to conclude, high residual risk of atherosclerotic heart disease and heart failure is present in type 2 diabetic patients. And the recent focus is to change from a glucose-centric approach to a comprehensive approach where all risk of complications are minimized, especially heart failure, atherosclerotic heart disease, microvascular disease is reduced. And when added to standard therapy, DAPA reduces the risk of worsening heart failure and cardiovascular events, improving symptoms in patients with the reduced ejection fraction heart failure with or without diabetes. And the relative and absolute risk reductions in death and hospitalization was there with or without diabetes. This drug is very commonly tolerated. Rate of treatment discontinuation is low in patients with or without diabetes. The common side effect with this drug, because increased.
Good evening, sir. Sir, can you confirm your name, please? I will change it, sir.
Yeah.
Sorry, sir.
Yeah. Yes, please go ahead.
Thank you so much, sir, for such an enlightening talk. Sir, is my voice audible to you?
Yeah, it is.
Right. Sir, I'll be asking you some questions that we have received on our portal. Sir, should we go ahead?
Yeah, go ahead.
Okay. Sir, first question that we have got, I think one of the doctors have asked that how should you titrate the dose of a diuretic if you are looking to add on a dapagliflozin or an SGLT2 inhibitor as a class?
For SGLT2 inhibitor, especially for dapagliflozin, for me, there is no, I hardly use 5 mg. More often than not, I start and persist with 10 mg. Okay. As far as the titration of a diuretic is concerned, there is no problem using thiazide diuretics, but loop diuretics, especially like furosemide, etc., maybe you have to just watch out and slightly reduce the dose to half.
Okay, so you would say that you have to reduce the dose to half in case of like if there's a volume overload still.
Yes.
Right. Okay. Sir, another question, doctor has asked, how would you start an ERNI, MRA and an SGLT2 inhibitor when you're looking to add, all these classes of drugs in a heart failure patient? Like, how would you go? What are the steps, one should follow?
I think earlier when dapagliflozin was introduced, a few years back, the usage of sacubitril valsartan combination, the usage of MRA, spironolactone, Spironolactone and this has no problem. We can use it together.
Right.
There is both can be started simultaneously also.
Okay, so hyperkalemia is not a concern.
No, not a concern. This is neutral for that.
Right. And
So-
if you want to add an ERNI on top of this, like all three.
ARNI, initially there was some, especially some warnings that ARNI should not be used if this drug is there. But right now, there is no such contraindication. It can be used together. In fact, it would be beneficial if both are used together.
Right, right. So I think all 4 classes of drugs should be there, as soon as possible as per the guidelines.
Yes.
Sir, another question, I think this is a cardiologist question. The person wants to know that what exactly is the hypoglycemia aspect of SGLT2 inhibitors, considering that you use it in a non-diabetic heart failure patient. So when you're using it in a non-diabetic heart failure, should one be worried about hypoglycemia?
Hardly see it. Hardly see it. It's very minimal. Both these group of drugs and gliptins have least incidence of hypoglycemia.
Okay, so I think there's no concern if you're using in just a heart failure patient.
Since it's not an insulin dependent mechanism, the chance of hypoglycemia is very minimal.
Right. So one question I just want to know from you, I think that nobody has asked, I just wanted to clarify. So why do you think the effect in heart failure is there? What is the mode of action? Is it just the diuretic action, or is it some other mode of action that is,
One of the theories which has been postulated is the ketone formation, the ketone body formation. This is acting as a cheap source of fuel and a very efficient source of fuel. So while everybody was scared of ketosis, it may be actually a protective phenomenon.
Okay. So that is one theory where it is showing beneficial for the heart.
There is one very well-known cardiologist who often lectures in India, Sundar Mudaliar. He was the main proponent of this theory.
Okay.
It was published as an editorial in the New England Journal of Medicine.
Right. So one other theory I think that has been going around, a lot regarding the diuretic action, and because of that, if the volume overload is less, probably less SNS activation. That is one theory, which was there. So I think we can say
also possible.
Right. So, one last question from the audience. Sir, one doctor wants to know that if you are using an SGLT2 inhibitor, sir, how cautioned you should be regarding a UTI? Like UTI is still there is a problem while initiating this drug.
See, it's all a matter of experience only. When we are seeing patients with UTI on this drug, used to stop this drug and then never restart. Now I do the following things. I start the patient with the dapagliflozin. If there's a UTI, I stop it. Then I tell the patient, and if he agrees, I restart it then after treating the UTI. Sometimes, especially if there's a fungal infection, I continue with dapagliflozin, don't stop it. I give fluconazole, 150 milligrams weekly for 8 weeks. That sort of prevents a recurrence of the fungal infection. Another good idea is to combine, if possible, to combine a gliptin with the SGLT2 inhibitor. How does this help? The gliptin has DPP8 and DPP9 cross-reactivity, which is in the genital tract, and that prevents more chance of infection in combination with the SGLT2 inhibitor.
So I think that was a very well explained answer. Sir, I would like to thank you on behalf of Curious Mankind for Charities for sparing time for us. I would like to now call upon our regional sales manager, Jyoti ji, to kindly give the word of thanks. I think it was a splendid session. I enjoyed a lot. I think listening, all the doctors must have also enjoyed. Thank you so much for your time, sir. Jyoti ji, over to you.
Thank you very much, sir, for your valuable time. And I just want to highlight, sir, our brand Justoza with our API DMF grade. That is the drug master file grade. It's internationally accepted quality standard we are providing, sir, to all the Indian patients. This API DMF comes from our manufacturing facilities approved by US FDA, EU GMP as well as WHO GMP, doctor. Thank you very much for all the doctors who attended this program. Definitely it will be very useful. Doctor shared all the personal experiences about DAPA as a molecule and also the cardio-renal metabolic actions. Thank you very much, sir, for your valuable time, and have safe.
Thank you.
And
Thank you so much, sir. Thank you. Thank you.